attending, so you'll cross paths with me more often this way. But I do endocrine consult 4 weeks in a year.
Okay, great. So I'm going to share my screen here. Let's see. Let's see if this. Oh, I have to grant access to Zoom. Give me 1 second. Let's see. Okay. Can everyone see the PowerPoint? Okay, great. All right, so let's start off this session. We're doing endocrinology today. And basically an overview of the agenda for today's session is we're gonna go over disorders of glucose metabolism, disorders of the pituitary gland, disorders of the adrenal glands, thyroid, and calcium bone disorders. So there's a lot that we have planned. I mean, there's endocrinology is just such a broadly encompassing field. So, you know, I just picked some high yield questions and you know, there's going to be some reading to do on your own as well. Just some points before we start off. If everyone can mute their phones, although I guess if you're muted on Zoom, we wouldn't be able to hear anything anyway. The use of your camera is optional, so feel free to turn off your camera if you choose to. And then we're going to be using Poll Everywhere today. So to join Poll Everywhere, if you text Carlita Shen 798 to the number 22333, it'll allow you to join on our poll. And basically for each question, if you text the letter that, the letter option that you choose, it'll reflect on the Poll Everywhere screen. So it should send you a text that you have joined once you send that text. And let me know if you have any problems with that. Okay, so let's move on to our first question. So before actually we start this first question, I do want to say that in terms of test taking strategy, I do encourage you guys to read questions before, or read the question itself before you read the body of the question. I feel like that really can focus your kind of sifting through all the information in the question to be able to focus things on what you're truly looking for in terms of the question itself. So the question itself for this, oh, and this is kind of blocked by, okay. The question itself is, which of the following is the most appropriate management of this patient's occasional fasting hyperglycemia? So usually I read that before reading the question stem. Oh, and now I can't go back. Okay, actually, give me 1 second. Okay, that kind of backfired on me. All right, so let's read the question. A 48-year-old woman returns for a follow-up visit for management of type 1 diabetes. She reports doing well since the last visit. Overall, she believes most of her blood glucose levels are at goal, but is concerned about occasional episodes of hyperglycemia occurring in the morning before breakfast. She eats a bedtime snack every night that is not covered with mealtime insulin. Review of her blood glucose log demonstrates morning fasting blood glucose values from 80 to 190. And her other pre-meal and bedtime values range from 100 to 120. She exercises 2 to 3 times per week in the evening, and medical history is significant for hypertension and hyperlipidemia. Her medications are insulin glargine, Lispro, Ramipril, simvastatin, and aspirin. And on exam, her blood pressure is 130/72, pulse is 67, BMI is 24, remainder of exam is unremarkable. Results of lab studies now show a hemoglobin A1C of 6.9, serum creatinine of 1, and her electrolytes are normal. So, like we read before, which of the following is the most appropriate management of her occasional fasting hyperglycemia? A, add insulin lispro at bedtime. B, add metformin. C, increase insulin glargine dose. D, measure 3 a.m. blood glucose level. Or E, continue current regimen. I'll give you guys a second to respond. Okay.
Just a quick note. It says the poll is full and it's received the maximum number of responses allowed.
Oh, okay. I did not realize that there was that option. So I guess only 25 of you can respond to these questions, it appears. So you guys have to respond quickly to get your answers in there if you want to be reflected. Thank you for letting me know about that. Okay, so let's look at the responses. All right, so 28% have chosen A, 8% B, 12% C, 16. Okay, so majority of you guys want to continue her current regimen. And then second runner up is add insulin lispro at bedtime. So does anyone want to unmute and kind of explain their reasoning for their response? Anyone? Okay, well, the answer to this—
I want to see the question again. Are we able to flip it back?
Yeah. Here we go. Yeah, so I guess the highlights of the question stem is that her morning blood glucose values were ranging from 80 to 190, and her bedtime values were 100 to 120. So I think, and I think in regards to choosing E, people may have been thinking that her A1C is 6.9%, which is at goal. So, you know, she may not need to change her insulin regimen. And then additionally, for answer choice A, adding the Lispro at bedtime, I feel like the thought is because she has these elevated levels of glucose in the morning, the occasional hyperglycemia, that it might be beneficial to add an additional dose of Lispro at bedtime. The answer actually is D, measure 3 a.m. blood glucose level. And I'll explain that here. So this goes back to the Samagi or dawn phenomena, and it's not as important to remember the actual names of these effects, but more so just the thought process behind it. Basically, it's saying that elevated morning blood glucose levels can be related to nocturnal hypoglycemia, basically due to a compensatory response causing release of catecholamines, cortisol, growth hormone, glucagon, and then results in having morning hyperglycemia, versus dawn phenomena where you have fasting hyperglycemia related to inadequate dosing of your basal insulin. So either one of these can be an effect here. And that's the reason why measuring the 3 a.m. blood glucose is important to distinguish between the two. Because ultimately, if she has episodes of hypoglycemia overnight, that's causing the compensatory hyperglycemia, it would be it wouldn't be a good choice to add a fast-acting insulin at bedtime, because that can risk in worsening the hypoglycemia. And in regard to not changing her regimen, so despite her having an A1C that is technically at goal, if she does have these overnight episodes of hypoglycemia, it's still important to adjust her insulin regimen despite that. Okay. And so overall, with the basics of diabetes management, I'm sure we all know, for type 1 diabetes, using physiologic insulin therapy, and then for type 2 diabetes, first line being lifestyle modifications, and then additionally metformin. And then I wanted to go over other oral pharmacologic agents. There weren't any questions specifically on the MKSAP question bank regarding these, but I think the side effects of these agents can be pretty high yield in terms of the board's exam itself. And then for markedly elevated A1Cs, so greater than 8.5 to 9%, you can just start insulin from the get-go. And the goal of treatment is targeting an A1C of 7 to 8% for most patients. But for some patients, it's important to not have that target A1C just based on their comorbidities. So usually that's people who have a lower life expectancy, people who are greater than 80 years of age, or have other chronic medical conditions like end-stage renal disease, COPD, CHF. And then going over the pharmacologic agents. So the important part here is just making sure that you know the side effects of these medications. So for the sulfonylureas, making sure that you know that they can have the side effect of hypoglycemia and weight gain. So for someone who wants to lose weight, that might not be the best choice. For metformin, lactic acidosis, and you want to be careful in patients who have progressive liver, kidney, or cardiac failure. And then most commonly is diarrhea and abdominal discomfort. And then for the thiazolidinediones, which I have a hard time pronouncing, you want to watch out for fluid retention in patients with heart failure. So I want to hold their pioglitazone if they're on that medication. And then for the GLP-1 mimetics, so exenatide, liraglutide, you want to watch out for pancreatitis and increased risk of chronic kidney disease. For DPP-4 inhibitors, so the gliptins, you want to also watch out for pancreatitis. And then for SGL2 inhibitors, you want to watch out for candidal genital infections, urinary tract infections, and then importantly, euglycemic DKA, which can often be missed because, like the name implies, patients are usually have glucoses in the 200, less than 200 range, but will have DKA. So, if Dr. Chao, if you have anything to add to that.
The only thing I want to add is that the dawn phenomenon is actually mostly driven by the morning surge in cortisol. Not everybody has this, but some patients certainly could be sensitive to that, and that's true for patients with type 1 and type 2 diabetes. And then the other answers are not wrong, except that you do need to rule out overnight hypoglycemia first before going to the other options. And then last thing is that even though the A1C target is there, you do need to make sure that someone with a very good, quote unquote, very good A1C is not having hypoglycemia to bring the A1C down.
Great, thank you. Okay, does anyone have any questions? Okay.
I have a question. I was wondering if you can explain the mechanism of the euglycemic decay.
Ooh, that's a good question.
So the mechanism of euglycemic decay is that in the SGLT2 inhibitors, the way that it lowers blood sugar is by having renal excretion of the glucose. So when renal excretion of the glucose happens, then the serum blood glucose is then lowered to what we call normal range. Without an increase in blood sugar, then there's even less endogenous insulin going to be present. And that's going to lessen the inhibitive effect on the ketoacidosis.
Thank you.
Thanks, Dr. Chao. All right. Yeah, if you guys have any questions, feel free to unmute yourselves at any point, but usually after the question, I will give you guys some time to speak up if you have anything, any thoughts. Okay, question 2. 24-year-old woman evaluated for 3 months of galactorrhea, worsening fatigue, and malaise. She was well 6 months ago and without explanation began feeling tired and lethargic. She has noted milk leaking spontaneously from her breasts. Her menses have been unpredictable. She had a normal cycle 3 months ago and 4 months ago, but then her next cycle was delayed. Her last menstrual period was 6 weeks ago and she had excessive bleeding. She has stopped exercising and has gained 3.6 kilograms. She also reports headaches that occur about 2 to 3 times per week. She has noted constipation and breast tenderness. She has no libido, which is a significant change. She took a home pregnancy test, which was negative. She has a history of depression. There is no family history of pituitary disease. Her only medication is sertraline for depression. On physical exam, her temperature is 37.2, blood pressure 118/68, pulse 72, and respiration rate is 10. BMI is 28, otherwise her physical exam is unremarkable. For her labs, her HCG was negative, prolactin is 68, TSH is 15, and free T4 is 0.82. Okay, which of the following is the most appropriate management? A, begin cabergoline. B, begin levothyroxine. C, hold sertraline and retest. Or D, order pituitary MRI. I'll give you guys a moment to respond.
And Carlita, if you'd like, there's a poll that we can use within Zoom as well. I think Javel just launched it, just so that results can come in and all 70 residents can participate, if that makes it easier.
Yeah, let's do that. Is there anything I need to do from my end for the quick poll? No, okay.
No, yeah, there's nothing you need to do. I got it. I'm going to end the polling right now.
Okay, great. Okay. So results are majority chose order pituitary MRI. Next up was hold sertraline and retest. Then begin levothyroxine, and then lastly begin cabergoline. Okay, so let me just go back to why this is, oh, here we go. Okay, so going back to the lab studies for this patient, her prolactin level is elevated, her thyroid, her TSH is elevated, and her free T4 is low. So the answer is B, begin levothyroxine. And let me just pull up the next slide to explain. So for causes of hyperprolactinemia, which this patient has, there's a multitude of causes, beginning with pregnancy, nipple stimulation, prolactinoma, and then importantly, there are medications that can cause elevated levels of prolactin. So antipsychotics related to their anti-dopaminergic effects, which can stop the inhibition of prolactin by dopamine. And then metoclopramide is another medication, methyl-dopa, verapamil, but I think most commonly tested is going to be the antipsychotics and metoclopramide. Another cause is primary hypothyroidism. And so that's something else to look out for patients. And then a non-functioning pituitary adenoma can also be a cause by compressing the pituitary stalk and decreasing dopamine inhibition, similarly to the medications like the antipsychotics. And then less commonly, CKD and chest wall injury can also prompt a hyperprolactinemia picture. So importantly for treatment of hyperprolactinemia, it's important to look out for these secondary causes of elevated prolactin. So looking out for medications that patients may be on, and I think that's what prompted people to choose the hold sertraline, although sertraline is not one of the medications that can cause hyperprolactinemia. So that is why that answer is not correct. The other answer choice that was popular is order a pituitary MRI. So that would be reasonable once you're able to kind of rule out the other secondary causes. And for this patient, because she has evidence of hypothyroidism, it would be most beneficial for her to start levothyroxine to correct for the hypothyroidism, and then retest in 4 to 6 weeks after starting the levothyroxine. And so the next slide is kind of the same thoughts that I just described. So for treatment of hyperprolactinemia, you want to screen for secondary causes first. Then for microprolactinomas that don't have symptoms of hypogonadism, you don't actually need to treat. But for symptomatic microadenomas, you can use OCPs or dopamine agonists, which were the cabergoline or bromocriptine. And even for macroadenomas, you can start with using medications over surgery for first-line therapy because they're pretty effective for decreasing the size of even larger adenomas. Dr. Chao, I'm going to pass it on to you if you have any.
May I ask one quick question? You mentioned the MRI. Was the MRI also not indicated because the TSH was elevated? And if it was an infarction of the pituitary, would the TSH be inappropriately suppressed? Does that also help us out with the labs?
So I'll answer your question. So if you encounter any endocrinology related questions on your board exam or in real life, the rule of thumb is, well, definitely rule out the secondary causes first. And then the second thing is endocrinologists like to complete the biochemical testing before any imaging or procedures or treatment. So you always have to go in that order. And then the third thing is, as you've already seen on the slides, there are multiple secondary causes causing hyperprolactinemia. Prolactinoma typically will have a prolactin level of 150 or higher. So anything lower than that is unlikely to be a prolactinoma, even though a microadenoma in the pituitary gland is still possible with a stalk compression. So if you see a value less than that, start with the secondary causes first. And then once you have completed all the biochemical testing, then you will move on to MRI if that's still suspected. And then the other thing is if it's a pituitary etiology, we commonly screen for other pituitary axis, including growth hormone, thyroid hormone, gonadal axis, and also HPA axis. So if you have other biochemical indications of hyposecretion or hypersecretion, then it's also reasonable to go on to the MRI. And then one correction on the slide, sorry I didn't catch this earlier, it's actually symptomatic prolactinomas that are going to be responsive to the OCPs and dopamine agonists.
Sorry, I have one more question that's also related to that. I think in the question stem, it mentioned that she had headaches. I don't know if she had changes in her vision or anything else, but is there other reason why you would jump straight to getting an MRI first before you do like kind of the more stepwise biochemical workup?
So actually, it's not very time consuming to complete the blood tests. So we still go with the blood tests first. But of course, things can also be done relatively quickly one after another. Just having a headache may not necessarily indicate that this patient has a pituitary etiology, but certainly if patients have severe headache that is concurrent with acute vision change, then that's concerning for pituitary apoplexy. In that case, you certainly want to move very quickly, and that patient probably should be evaluated in the ED.
Great, thank you, Dr. Chao. Any other questions regarding this question? Okay. All right, moving on to question 3. A 74-year-old woman is evaluated for diagnosis of primary hyperparathyroidism made after an elevated serum calcium level was incidentally discovered on laboratory studies. She has no symptoms associated with hypercalcemia. Medical history is significant for hypertension and chronic kidney disease. Her only medication is amlodipine. She has never smoked. On physical exam, temperature is 36.8, blood pressure 134/87, pulse 92, respirations 14, and her BMI is 27. Remainder of exam is unremarkable. For her lab studies, her calcium is 11.3, creatinine 1.3, parathyroid hormone is 76, and her GFR is 40. The DEXA scan shows a T-score of -1.3 in the right femoral neck. Her FRAX score indicates a 2.1% 10-year probability of hip fracture and a 17% 10-year probability of any fracture. Which of the following is most appropriate, the most appropriate therapy to recommend to this patient? A, alendronate, B, cinacalcet, C, parathyroidectomy, or D, clinical observation. And let me go back to the labs for you guys. And I'll go back to the answer choices there.
We have about half the people who've completed, so I'll end the poll.
Okay. All right. Responses are, looks like A and D are the most popular responses. D wins by a couple percentage points. And then B and C are tied. So the correct answer for this question is C, a parathyroidectomy. And if you look back to the question itself, so this patient has evidence of hyperparathyroidism. She has an elevated calcium, elevated parathyroid level. And so this goes, next slide. So to explain the surgical indications for hyperparathyroidism, the indications are increase in serum calcium level above 1, equal to or greater than 1 above the upper limit of normal, creatinine clearance of less than 60, the DEXA scan T-score of less than or equal to 2.5, and age of less than 50, and in cases where medical surveillance is not desired or not possible, so for patients who may not be able to come back to clinic to repeat the DEXA scans. And then for the, so going back to the question itself, this patient does meet the criteria for a parathyroidectomy based on her calcium level, and let's see. So based on her calcium level, essentially.
Creatinine clearance 40.
Oh, and her creatinine clearance. Yeah, so her creatinine was 1.3, GFR 40. So based on her calcium level and her kidney dysfunction, she does qualify for a parathyroidectomy. For the other answer options for FRAX criteria, this is used only for treatment naive patients, which Dr. Chao added. And to explain the use of treatment for osteoporosis based on the FRAX criteria is dependent on the risk of major osteoporotic fracture greater than 20% or risk of hip fracture greater than 3%. So these patient populations would benefit from therapy. And the cinacalcet is used as an alternative for patients who are unable to or unwilling to undergo the parathyroidectomy. So that is an option for treatment, but only after the parathyroidectomy is ruled out.
So a common misconception for diagnosing primary hyperparathyroidism is that the PTH level has to be high. So that is a false assumption. So if patients have serum calcium level that is clearly above the normal threshold, and PTH is inappropriately in the mid to high normal range, that's still primary hyperparathyroidism. An additional surgical indication, which I typically also screen for, is to collect the 24-hour urine, calcium, and creatinine at the same time. The creatinine is collected to make sure that the specimen is an appropriate 24-hour collection, in addition to the volume assessment. And then if the calcium in the 24-hour urine collection is greater than 400, that's another indication for surgery. FRAX criteria, you'll encounter this in your primary care clinic, so you do need to know this, that FRAX can only be used in patients who's never received any treatment for osteoporosis, because that's the patient population they establish it on. And then lastly, osteoporosis is especially prominent in the distal radius. So in patients who have hyperparathyroidism of any form, this is a site that should be added to your typical lumbar spine and femoral neck. And the reason is because PTH's action is strongest on the cortical bone, which is found in the distal radius.
May I ask what we should use to estimate the risk of fracture in patients who are not treatment naive?
Your only bet is the DEXA scan, and also assessing for secondary risk factors. For example, has the patient had early menopause? Estrogen is the most important thing to protect against osteoporosis and fracture. It's the same whether it's male or female. So in the male, the testosterone is the one to check. And then other secondary risk factors, including glucocorticoids. So hyperparathyroidism is one, malabsorptive disorders, things like that.
Okay, I'm going to move on to question 4.
Kidney stones an indication as well?
Sorry, can you repeat the question?
Is having a kidney stone an indication for surgery?
Yes, because that's considered symptomatic hyperparathyroidism. So another surgical indication is symptoms from hypercalcemia.
Okay, great questions. Question 4. A 43-year-old woman is evaluated for progressive weight gain over the past 2 years. Her previous weight was 72.6 kilograms, but has steadily risen to her current weight of 106.6 kilograms. She notes a slight increase in her appetite, but minimal change in her lifestyle or activity level. She has tried to lose weight with increased exercise and nutritional counseling, but without significant results. More recently, she reports having trouble sleeping and decreased exercise tolerance with activities such as walking up steps. Medical history is significant for impaired fasting glucose, hypertension, and hyperlipidemia. Medications are hydrochlorothiazide and atorvastatin. She has not been prescribed glucocorticoids or had glucocorticoid joint injections. Which of the following is the most important next step in evaluation? A, ACTH hormone measurement. B, 1 milligram dexamethasone suppression test. C, 8 milligram dexamethasone suppression test. D, pituitary MRI. And E, serum cortisol measurement. And
did we miss a slide on the lab? There's a question. Yep.
mm-hmm. Oh, yes, we did not go over this part. So to summarize this portion of the question, she has rounded facies, thin hair, mild hirsutism, prominent fat deposition. Her skin is thin, bruises easily, striae are not present. Those are the remarkable parts of her exam. And then for lab studies, her fasting plasma glucose level is 120 and she has a normal TSH.
Can you show us the answer options again, please?
Yes, go back, okay.
So the question really is, what do you think this patient has, and what biochemical evaluation should you pursue next, or imaging?
All right, poll results are back and it looks like B got the majority of the choices, and that is the correct answer. So 1 milligram dexamethasone suppression test. Good job, everyone. And so basically, her exam is consistent with findings that, that you would see with Cushing's disease. So she has rounded facies, thin hair, mild hirsutism, prominent fat deposition, skin is thin, bruises easily. And because of those findings, you want to screen for Cushing syndrome. So biochemical evidence of hypercortisolism must be confirmed. And there are a few screening tests that are available. The 1 milligram dexamethasone suppression test, which you guys correctly chose from the answer choices. 24-hour urine-free cortisol excretion or measurement of evening salivary cortisol. Although within these screening tests, the dexamethasone suppression test is the most sensitive. So generally, the preferred choice amongst the available tests. And then 2 abnormal first-line screening tests are usually required for diagnosis. And that doesn't mean 2 separate tests. It could be the same test.
We usually do 2 different ones.
Oh, okay. Never mind. Thank you, Dr. Chao. And to explain the other answer choices, so one of them was ACTH level. So that's used to determine if the hypercortisolism is ACTH dependent or independent, not necessarily to diagnose the Cushing syndrome. The 8 milligram dexamethasone suppression test is used to differentiate between Cushing disease, so a pituitary tumor secreting ACTH, and an ectopic ACTH production. The pituitary MRI is if pituitary adenoma is the suspected cause of Cushing syndrome. And then serum cortisol is not generally used as a screening test due to variations in the cortisol level not being a very sensitive test. Okay, I'm going to pause for any questions, any additions. Okay.
Carlita, do you want to answer that one? Or do you want me to?
Is there a question?
Question was, when would you get a salivary or urine cortisol? So I'll go ahead and take that. So when you suspect Cushing's, and then if you really all 3 tests are equally good, when you want to evaluate for Cushing's, the 1 milligram overnight dexamethasone test is especially good if you suspect subclinical Cushing's. For subclinical Cushing's, that is the go-to test. So when someone has multiple symptoms suggestive of Cushing's, then you can do any of the 3. So you need to have at least 2 abnormal ones to establish the diagnosis. So just pick 2 of the 3.
And I think we've actually rapidly come to 9:45. And so just to be respectful of everybody's time, even if there's more MKSAP content, we may have to pause the presentation here. Everyone will have a break for 10 minutes. I want to thank Drs. Chao and Dr. Shen so much for walking us through MKSAP endocrinology. And maybe if there are some other questions during the break time that you guys have, either to add them into the chat or maybe our 2 experts will stick around for a couple of minutes to answer anything, but otherwise you guys are free until 9:55.
And feel free to send us any emails if you guys have additional questions. We can always answer via email.